Thank you, Katrina. Yeah, so let's talk about some how hypertensive disorders of pregnancy increase cardiovascular disease risk in women and what we can do about it. These are my humble objectives with this talk. First of all, my goal was to, with this presentation, maybe delineate an actionable roadmap where to implement this vision for equity and helping women in their overall cardiovascular health. Also, I want to bring awareness about between the healthcare different workers about how women have sex-specific risk factors. Also, I want to try to promote a standardized approach so we can provide timely diagnosis, treatment, and follow-up for women who have had elevated blood pressure during their pregnancy, and emphasize that the importance of having an interdisciplinary approach where all the different members of the healthcare team can have their can help us promote and increase and help us decrease the risk for women across the whole life. Ultimately, why this matters, I really like this phrase by Michelle Obama that says, communities and countries and ultimately the world are only as strong as the health of their women. I love this phrase for many reasons, but we all are very aware that every member of our community matters. And in my talk right now is just to bring forward women, but any member of our community, we all are going to be as strong as any member of our community will be. So that's why I'm bringing this forward. So spoiler alert, I'm not an expert by any means about this. I try to review the most current and up-to-date research and data, and this is what I'm bringing forward. I basically, most of the information I'm bringing you today, it comes from these 4 studies that I listed over there, and these 4 studies I've done in the last 3 years, so hopefully it's the most current information at least I had access to. So but I mean, I'm not expert. Also, I want to bring forward the fact that language is important, but the way that we talk, our terminology is always evolving, just like we are evolving. So I also want to acknowledge that there is individuals' identities are important, and there are many identities that in most of these studies, the way that they're referenced to women was a sex assigned at birth, and they were compared to women where most of the studies were comparing women to men. In this presentation and in the slides, I use the term women or birthing individuals to try to be more inclusive. So let's review epidemiology. Let me tell you, when you start researching epidemiology for cardiovascular disease, there is so much more data that we have, and there is a lot, and it's very interesting. I try to keep it short, and so I can go to the main goal of my presentation, but there's so much more. So I'm just going to put a lot of small verbs that can help us get it will help me paint a broader stroke, but by no means this is not extensive. So up to this day, the most common cause of death in the United States and most developed nations is cardiovascular disease. Thankfully, the mortality rates have decreased over the past 40 years, and this have been accomplished especially in women and men older than 65 years old. However, women younger than 55 years old only had experienced a small decline in mortality. And what the experts have observed is that there has been an increase in hospitalizations for acute myocardial infarction in women younger than 55 years old. There is still cardiovascular disease is understudied underdiagnosed and undertreated in women. If you take a look at all the studies, most of them the studies that we have got most of the guidelines for treating cardiovascular disease, they either did not include women or they included in a very small percentage. This bias has resulted in women being disproportionately affected by cardiovascular disease when you compare it to men. Studies also show that women receive less aggressive treatment and are less likely to be prescribed guideline-directed therapies when you compare it to men. And this disparity is partially due to difference in symptoms, presentation, and lack of awareness among healthcare providers about sex-specific risk factors. And that's what I want to try to do with my talk, is bring awareness about these differences. So I chose a couple of slides from the Go Red campaign from the American Heart Association. I thought they were really graphic and I liked them. So just to think about, in this moment, 1 out of 3 women are living with cardiovascular disease, and some of them are completely silent. Another interesting fact is 64% of women who died of coronary heart disease had no prior symptoms. And among the women, there are some groups that are affected more than others. I chose these other 2 interesting facts, that Hispanic or Latino women will present with heart disease 10 years earlier than women that are not Hispanics. And African American women could also, the cardiovascular disease deaths are highest among this group, and they're 2 times more at risk of stroke. I thought that those were shocking statistics. So how does this impact AHEC's core topics? Well, particularly in the context of hypertensive disorders of pregnancy, this affects because we try to address disparities, and when it comes to social determinants of health, interprofessional education, and health equity and disparities. So hopefully this can help my talk. So when we talk about women and men, what are some of the differences? I put a little drawing about an emergency room, and I found that one of the most remarkable differences is how we present with cardiovascular disease. Women will present more with essential hypertension, hypertensive crisis, arrhythmias like atrial fibrillation, flutter, supraventricular tachycardia, pulmonary embolism, or ischemic stroke, when men will present more myocardial infarction and cardiac arrest. There is this great article that was published in the Journal American Heart Association that review 20.6 million encounters in the ED due to cardiovascular disease, and they showed the difference between men and women. And I found this very interesting graphic that showed of those encounters, 10 million of those were women, and the median age was later was 69 years old. And women usually had more hypertension, more obesity, more anemia, and more cerebrovascular disease. If you look at the bars graphic and underneath it, you will see that in what percentages women presented, women presented with essential hypertension in 16%, and men in 10.8%. When it comes to AFib, sorry, and flutter, women presented in 10.2%, so higher. When it came to PE, 3.3%. So we obviously present in a different way, and this means disease, but also symptoms, right? So ischemic heart disease remains the leading cause of death, and however, the manifestation of disease, treatment, and health outcomes are influenced both by sex and gender factors. So when we talk about sex differences, we're talking about biological factors like hormonal influences, anatomic differences, like coronary arteries are smaller in women than men, that can produce a technical difficulty or difference when choosing some treatment options for women. But there's also a difference in gender and how women behave in society and the roles that are portrayed by them. And this makes a difference in how we approach treatment and the health outcome. And this is what we're going to talk about today. Women between the age of 45 and 74 years old have a higher mortality after a first myocardial infarction when you compare it with men. And this is because women are less likely to have aggressive risk reduction advice or guidelines-derived treatment when you compare it with men. So I think it's imperative that clinicians understand the sex-specific ischemic heart disease differences in women to help improve their outcome. So I really like this other graphic. In the darker red is showing what we call the traditional cardiovascular risk factors, and this have been well studied, and we have plenty of research, and we all have been taught about these risk factors in medical school, and this has been studied mostly in men. And those are hypertension, obesity, smoking, diabetes, dyslipidemia, and physical inactivity. However, there are some non-traditional risk factors that tend to be more common in women, and they are also sometimes can be as high as an impact in somebody's disease as the traditional ones that we sometimes don't have. We don't have them in mind, like pregnancy complications, psychosocial stress, low estrogen states, breast cancer treatment, autoimmune disease, and depression. So we also need to understand that the risk factors span a lifetime. They can go from young adulthood, like in this, when women are young, they're more susceptible to depression, premature menarche, polycystic ovarian syndrome, and autoimmune diseases like lupus and rheumatoid arthritis. When women are in childbearing age, then we open the door to risk factors all linked to pregnancy, like hypersensitive disorders of pregnancy, preterm delivery, small or large gestational age, placental abruption, pregnancy loss, and infertility. And even if women go through in vitro fertilization, that also implies a risk, increases the risk of cardiovascular disease. And when we think about late adulthood, we need to think about premature ovarian failure and premature menopause, also increasing the risk. So we can tell that when we treat our patients through the whole lifespan, their cardiovascular risk, we need to have that in mind. So what is the evidence? So for low estrogen, and I'll try not to be too technical and not bore you with numbers, but they're very important, and I hope you can track along. But obviously, you can have access to all the data and all the studies. All of them are I put them at the end of the slide, at the foot of the slide. Sorry. So. Low estrogen states like menopause or PCOS are very important. For menopause, the median time from menopause to the development of cardiovascular disease is 12 years. So the sooner the onset for menopause in a woman is, the increases the likelihood of them having an event. So, for instance, if from the age break of 45 to 49, you will have 2.6 events every 1,000 women. But if you look at the break age from 40 to 45, this goes up to 3 events per 1,000 women. If you go to younger than 40, then it increases to 4 events per 1,000 women. Also, like I talk about PCOS being can double the risk of CVD in women. This is the relative risk is 2.02. And although it is uncertain if this is linked to obesity, but it's well documented in PCOS. When it comes to autoimmune disease, autoimmune disease is way more prevalent in women. 80% of people with autoimmune disease are women. So this increases the risk, and the risk is very well documented in diseases like rheumatoid arthritis and lupus. When for rheumatoid arthritis, increases 50%. It's a higher mortality rate when women have rheumatoid arthritis, and also depends on the amount of flare-ups and how severe they are. And also with lupus, another study identified that 50-fold increase in the relative risk of myocardial infarction in young women from 35 years old to 44 if they have lupus. So that's very important. For psychosocial stress, and this is where having in mind social determinants of health are very important, because they increase the risk, especially in women, because women have a higher exposure to psychosocial stress and adversity than men. Women are more exposed to sexual violence, and they usually have higher rates of poverty when it comes to compare with men. And we all know how that can determine somebody's health. Also, in patients that had breast cancer and they have been treated for them, we know that some drugs like anthracyclines and trastuzumab can directly affect the myocardial tissue. Also, women that have received aromatase inhibitors or radiation therapy. And also, I want to bring up that radiation therapy not only is used in breast cancer, so any other patient who has been radiated in the chest also increases the risk. We need to have this in mind when we think about our patients that are breast cancer survivors. For depression, depression affects approximately 7% of the population every year. Of this, about twofold is more common in women than in men. And a clinical diagnosis of depression is associated with a doubling of risk of cardiovascular disease, even when you compare it to over a period of decades. So having a good assessment of mood disorders and offering treatment to our patient is very important. It can be, and it is a strategy to try to decrease the risk. But now the most important thing that I want to talk about is pregnancy complications, right? So adverse outcomes of pregnancies occur in 10 to 20% of all pregnancies. Think about your patients that you're providing prenatal care. 1 or 2 will have adverse outcome, and this will increase 1.8 to 4.0 fold risk of future cardiovascular disease. And this is being well documented, but also it increases the risk if the women have a more severe form of adverse outcome of pregnancy, or even if they had more events, like it happens in several pregnancies. Let's say women had preeclampsia, that increases their risk. But if they have preeclampsia in 3 different pregnancies, that increases even more their risk. This is all linked to an abnormal endothelial function. The endothelial, we all studied the endothelium as one layer of the histopathological tissue, but honestly, the endothelia is such an important and tissue when it comes to being the common pathway for early disease. So there's the studies, I named them at the bottom. So what are we talking about when we say adverse pregnancy outcomes? Well, that includes all hypertensive disorders of pregnancy, like gestational hypertension, preeclampsia, chronic hypertension, but also gestational diabetes, preterm birth, early preterm birth, pregnancy loss, and intrauterine growth restriction. Pre-existing, so what are we talking about? Hypersensitive disorders of pregnancy. I'm trying to be cognizant that maybe my audience is not all MD, so I try to have a little explanation of what are we talking about when we talk about hypersensitive disorders of pregnancy. And these are basically 6 disorders that have in common elevated blood pressure. This can be chronic hypertension, means that women had elevated blood pressure before getting pregnant, and this is continuous during pregnancy. Or gestational hypertension, it means that they have a new onset of hypertension during the pregnancy, and this is usually diagnosed from 20 weeks on after gestation. Could happen in superimposed preeclampsia, is continued hypertension during pregnancy plus preeclampsia. And preeclampsia is the new onset of hypertension during pregnancy, plus proteinuria. Patients can have visual and cerebral symptoms, low platelet count, renal insufficiency, and impaired liver function. There's also HELP syndrome, which is a syndrome where you will find hemolysis, elevated liver enzymes, and low platelet count, and eclampsia, where we found de novo seizures. And all of this have in common the elevated blood pressure. So are hypertensive disorder of pregnancy predictive of long-term cardiovascular disease? Absolutely, yes. The data is compelling. There are so many studies, and I put in my slide these 5 studies. These are observational studies conducted with very large populations, done in the UK, in France, in Taiwan, and also in the US. They have been very important to link the increasing risk in cardiovascular disease. So why is pregnancy such a marker of cardiovascular, can be such a marker? Well, essentially, pregnancy is a stress test for women. And we can use this adverse pregnancy outcomes to identify women who have or will have an increased risk for cardiovascular disease, even if these conditions resolve after delivery. We need to think that when we perform a stress test, it's usually for minutes, like 15 minutes, 10 minutes, 5 minutes, depends on how much that person can go. Well, a stress test in pregnancy is a stress test that lasts 40 weeks with increasing workload, right? So it gives us a lot of information. So I put some of the data that one of the studies found. This is a study done I gave this data from the study from Honigberg and collaborators, and they found that coronary artery disease, the hazard ratio increases to 1.8% when you compare it to women who did not have elevated blood pressure during pregnancy. For heart failure, increases 1.7. For aortic stenosis, increases 2.9. And for mitral regurgitation, 5.0. And all of those have a significant p-value. And so it's significant. I really like this graphic here because it shows us that these 4 diseases increase the risk during pregnancy, but it also shows us in the different graphics below in comparison with women or individuals who actually didn't have elevated blood pressure. So you can tell for coronary disease, which is the buildup plaque that can decrease the blood flow to the heart, that incidence increases with age, but also there's a marked difference between hypertensive disorders of pregnancy, which is marked in red, and those who didn't, which are marked in blue. And the same for heart failure, which is the failure of the heart to pump, to assist as a pump. And the aortic stenosis, also showing the steep increase in the curve. The hazard ratio increases 2.9%, and for mitral regurgitation is 5.0. So, like I said, the data is very compelling. Also, in this study, they showed that prevalence of hypertension increases with age. And we can see that women who had hypertensive disorders of pregnancy had more hypertension than women who did not during their pregnancy. And we can see this in each age break. In red, you see the HDP, so it's very compelling. Also, the number of incident of cardiovascular disease per 1,000 women, it's different between women who had elevated blood pressure in pregnancy from those who didn't. Again, in red, those who did, and it increases. When women approach 65 to 69% is about the same, and that's because in older age that there's more risk for cardiovascular disease. Also, another thing that is important is that not only that a woman had an episode of hypertension disorder of pregnancy, but also the severity of the episode. Like, if a woman had preeclampsia before 37 weeks of pregnancy, the risk increases to 8-fold for ischemic heart disease and 5-fold for stroke. So the severity also increases the risk. A recent study also showed that pregnant women with pre-E have 2-fold higher risk of identifiable coronary artery calcium in a CT scan at the age of 50 when you compare it to a referencing population. So for chronic hypertension, if you, in the age break of 35 to 40 years old, if you look at women with hypertensive disorders of pregnancy, one out of 9 will have a clinically relevant hypertension. But when you compare it with women who had a normal blood pressure, it's 1 in 38. So, like I said, all the data, it's very compelling. But also, you see the risk with miscarriage also increases. The odds ratio increases to 1.45. If they had recurrent miscarriage, then it goes up to 1.99. If a woman had obesity or excessive weight gain, also the risk increases. The hazard ratio increases to 2.63. Even when you compare it with women who maintain a normal weight, and the stroke risk goes up 1.89. Also, when you compare it with women who had a healthy weight. In women who had obstructive sleep apnea, there is no data that says to increase the cardiovascular risk, but increases the adverse pregnancy condition, so it's reported as a pool odds ratio. For placental eruption, also increases the ratio to 1.8, and preterm birth also depends on if it's preterm before 32 weeks or not, but also, like you can see, the numbers increases. So you would think if we know that this has been so well studied, and we know the data is showing us that increases the cardiovascular risk, how can we predict? Can I, with this data, predict my patient's risk particularly? And although adverse pregnancy outcomes are associated with later risk of cardiovascular disease, the addition of pregnancy complications to standard cardiovascular risk prediction models have not significantly enhanced the predictivity of capabilities. So even though we know this, it's hard to come up with a risk calculator for every woman that we see in our clinics. So then if we cannot measure risk for each patient, then what should be our approach to prevention? Well, there is a lot of discussion on how to do this, but there are some recommendations on how to use this data to better treat our patients and inform them in order to improve their cardiovascular health. Well, I think all the experts and the guidelines, they all come up to consensus of we need to individualize the risk for each one of our patients. So one of the first things that ACOG recommends, and this is very important for all of us who do primary care, is to document that very well in the EMR that this patient had pregnancy, adverse pregnancy condition. So the primary care team and other teams taking care of the women in the rest of their span of their lives can be communicated of the risk. Another thing that we can do is we can empower our patients. So informing our patients of their increased risk can actually help them make informed lifestyle choices. And this has been very important because there are studies that show that women tend to be more compliant when it comes to medical advice and compared to men, and particularly in the context of managing cardiovascular disease, and including those who have had episodes of elevated blood pressure during their pregnancy. So empowering our patient is very, very important. So what are the experts saying? What are they recommending? How should we manage? How should we follow up with these patients after their delivery? So the first thing is that ACOG says that recommends that we should assess cardiovascular risk. We should do a screening within 3 months of postpartum. And if you take a look at the graphic next to to the left, there are some conditions that we need to be following our patients for. This includes all hypertensive disorders of pregnancy, but also IUGR, preterm birth, placental abruption, diabetes mellitus, gestational diabetes, obesity, or excessive pregnancy weight gain, sleep disorders, or if our patients are older than 40 years old. How we do that? We do need to schedule an appointment for a 3 months follow-up for cardiovascular risk screening, where we should do a good medical history with a smoking history, physical activity, finding out for the breastfeeding, if they have a history of hypertension, diabetes, family history. We also need to do a thorough physical examination with making sure that we have a good blood pressure, a rest, a heart rate. We calculate the body mass index and also the waist circumference. And we should do some labs like a lipid profile. We should screen for diabetes, and we should do a urine protein creatinine ratio. So when it comes to diabetes screening, what we usually do for the popular generation is we start at 35 years old, and if somebody has another risk factor, we might start earlier. But in women who had hypertension disorder of pregnancy, then we need to screen at 4 to 12 weeks of postpartum. Generally in our program, we do it at 6 weeks with a 2-hour tolerance test, glucose tolerance test, sorry. If this is abnormal, we need to treat it as diabetes. If it's not, we need to continue to monitor, and the experts are recommended once a year, and we need to try to reduce the risk, the other risk factors. I got this table from one of the recommendations from the experts comparing what the different associations were doing. And when you compare, we're recommending the American Diabetes Association and the American College of Cardiology and the American Heart Association. They both recommend a goal for the A1C to be under 7%. But interesting, the European Society of Cardiology is saying 7 in general, but if women are not having any episodes of hypoglycemia, then the goal can be reduced to 6.5, which I think with the new medication for diabetes, that goal is more safely, we can achieve it more safely now. So when it comes to blood cholesterol management in women, what there are no specific guidelines, but what the authors are recommending is to screen for with lipid panel 1 year after delivery in patients who did not have any lipid screen recently. So I really like this graphic because it's very easy to follow it, but it's showing like the traffic lights is saying in green what we should do, red no, and yellow and maybe. So when it comes to giving statins, prescribing statins for cardiovascular prevention in women, we should do it in every woman who has for secondary prevention. And patients who had a history of AMI, and patients who have a history of acute coronary syndrome, who had peripheral artery disease, stroke, etc., they all need a statin, no doubt about it. Also, for primary hyperlipidemia, if LDL is more than 190 milligrams per deciliter, we should prescribe statin. If women have diabetes, if we want to do primary prevention, in women from 40 to 75 years old, if the risk is more than 20, or they have an intermediate risk between 7.5 to less than 20, plus race enhancers, they should get a statin. Who should not get a statin? Women for primary prevention in women that are 40 to 75 years old with a very low risk, less than 5%, or any woman who is pregnant or is intending to be pregnant in the next 1 to 2 months. And maybe we need to do it for primary prevention in women who are aged from 40 to 75 years old with a borderline risk and with risk enhancers. And this is all the risks that we've been talking about. And this is can be a shared decision with patients if they want to start a statin or not. I just put this slide just to say that in women who are pregnant, the main treatment for hyperlipidemia would be lifestyle changes, but if not, we can use bile acid sequestrants. So once our patients have an established diagnosis of hypertensive disorders of pregnancy, what the experts are recommending is that we calculate the ACVD risk in 10 years. We can also add to increase the capabilities of the predictive capabilities, the coronary artery calcium score, and that can increase how much we can predict. So if a woman's risk is low, is from 0 to less than 5, then statins are not recommended. But if you perform a coronary artery calcium score and is more than 0, you can consider starting a statin. And that will be a shared decision with the patient. If the risk is borderline, is between 5% to less than 7.5%, you can consider a statin. But if you add the coronary artery calcium score and is more than 0, then the experts are recommending the statin. If the risk is intermediate, between 7.5 to less than 20, definitely recommend a statin, especially if their coronary artery calcium score is more than 0. If the risk is more than 20, definitely the indication is for a statin. For hypertension, what are the recommendations? Well, we need to recognize that chronic hypertension contributes the greatest risk of developing cardiovascular disease. Individuals who had hypertension disorders for pregnancy have 12 to 24-fold greater risk of developing chronic hypertension in the first year after delivery when you compare it with women or birthing individuals who didn't have elevated blood pressure. This is what the what the experts are recommended. If after Our Lady's had the delivery and we're doing our 3 months appointment for screening for cardiovascular risk, if they have a normal blood pressure, meaning less than 120/80, we promote healthy lifestyle and we follow up with them in a year. If it's elevated, it's between 120 to 129 over less than 80, we indicate some lifestyle changes and we follow up with them in 3 to 6 months. If we find that their blood pressure is between 130 to 139 over 80 to 89 millimeters of mercury, that is stage 1 hypertension, and they have clinical, like a high atherosclerotic cardiovascular disease risk, then we should do lifestyle changes and we start blood pressure medications and we follow up with them in a month. If their risk is low, then we can implement lifestyle changes in 3 to 6 months. And if the blood pressure is still elevated, then we need to have a shared decision about starting blood pressure medications. But if the blood pressure is more than 140/90, this will be a stage 2 hypertension. Then we implement lifestyle changes and we give blood pressure medication and we follow up with them in a month. Yeah. So, and what are the lifestyle recommendations and weight management? Probably I should be talking about this slide for hours, but I'm just going to mention that all the consensus says that we should try to encourage our patients to have at least 150 minutes a week for moderate to intense activity. We should promote a DASH diet, which is a dietary approach to stop hypertension, and it's a diet that is tries to decrease sodium intake, and also Mediterranean diet or a plant-based diet. We need to encourage our patients to minimize alcohol consumption and promote smoke cessation, especially. We also want to try to encourage patients to continue lactation. Breastfeeding is associated with improved cardiovascular health, and it includes lower incidence of type 2 diabetes, hypertension, and coronary disease. So we need to encourage our mothers to keep breastfeeding and helping them with that task. So what about adding additional tools for cardiovascular disease risk stratification? One tool that we can use is it's coronary calcium scoring. This is done by performing a CT, but this is a low dose, and we'll basically identify calcium buildup in the coronary arteries, and it will give us a score. If a score is 0, indicates low risk, and then our patients, the indication for statin is less important. And if there is any calcium, then that increases the risk. So I'll pass this, and I'll show you, these are some examples of CTs where the score is 0. It means no calcium is detected. The score can go from 1 to 100, and this is a mildly increased risk of heart disease. And you can see the calcium buildup. It shows up in white. 101 to 289, this is moderately increased risk of heart disease. And when the score is more than 300, we're talking about moderately to severely increased risk of heart disease. So you can perform the study and make it more informed decision on when to start statin or prevention. So how does this topic impacting interprofessional team? I think we all have our role in trying to decrease the risk in our patients. Specialists like MFM, OB providers, including OBGYNs and family medicine and cardiologists, they all have the role of are the ones that initiate appropriate interventions. They follow patients during their pregnancy, and they might follow up with them after their deliveries. So they're key in diagnosing our patients. Also, primary care providers are the ones that are in charge of mitigating the long-term risk. Nurses and nurse practitioners also sometimes can follow up with patients, and they do the blood pressure controls, and they're very important. Pharmacists can help us, and they can contribute in making sure that we adhere to guidelines and that our patients get the medication that they need, and they also can help our patients to get their medications. Dietitians and nutritionists can support healthy eating habits and weight management. And social workers and community health workers are very important because they help us address social determinants of health. They provide support for accessing healthcare services and assist with care coordination. Yeah, so all of us have a role to help decrease the risk. So conclusions. I try to keep my conclusions very, very simple, because if you could take one idea from my presentation, is that 80% of cardiovascular diseases are preventable. Some studies say up to 90% are preventable with lifestyle choices, exercise, healthy eating, weight management, cessation of alcohol or smoking. And also it's preventable if we start medication when patient needed, like diabetes control and also treat hyperlipidemia. And another takeaway from my talk is that risk reduction strategies need to be tailored to each patient. So for that, we need to know our patients, know their personal medical history, know the history during pregnancy, so we can tailor our approach. I use many references, and you will have them in there. And thank you for listening. I'll try to respond to any questions, but I also invite any comments that anybody would like to do. I don't know if in the chat we have any questions. Oh, no.
I don't see any questions in the chat.
Hey, Dr. Carbonell, it's Abby. I thought that was an excellent talk, and really kind of fixed in my mind that while I think about things like gestational diabetes and chronic hypertension or gestational hypertension in this realm, I was not thinking about things like IUGR and placental abruption. And so that was really helpful to sort of think about that long-term cardiovascular risk more broadly than I think we often do.
Yeah, I have to confess that when I started studying, my title was, I was narrowing my view just to hypertensive disorders of pregnancy, but then I was found with so much data, and with some other diseases and disorders that can increase risk in women, that I had to put in my presentation. So it's a little bit more broad than my title, as you can tell.
No, it was great. Thank you. I learned a ton.
Thanks.
Yeah, I have a question. With electronic health records and problem lists, is there a place to retain basically the hypertensive disorders of pregnancy and a quality or quantity value as to how many they've had, and you could add to it over time. So as a person's quickly reviewing the problem list, they would see that, hypertensive disorders of pregnancy, 10 episodes. I know this patient's at much higher risk than one with 2 episodes or none.
I believe in our EMR, we can introduce what it calls obstetric history, and then we can put in there. That can always be improved, and that can be conversation with the people that designed this. But the fact that ACOG is saying that the primary care team needs to be aware of the risk, this is information that needs to be followed the patient's lifetime. And I would say that other thing that increases the chances of that this knowledge be passed on is that the patients know. If the patients are aware of their own risk and they're aware of their history, and we make them know that that's an important diagnosis that they had and why the risk, that will be carried on, even if we make the mistake of not including in the EMR. But I found that that's an easy thing that we can all do in primary care, and I thought that was interesting that ACOG put it at the first thing, which this information should carry on somebody's life.
Yeah, point appreciated. Yeah, I remember times when I would calculate somebody's atherosclerotic cardiovascular disease risk, and really never gave this a thought. And I wonder if resources like MD Calcs will be adding this to some of their calculators.
Yeah, when I was doing my talk, my presentation, I was thinking, I really hope my presentation is outdated very soon, so we can have this in calculators, so all our emergency docs can calculate somebody's risk easily. But like I said, they have tried to include it, and they were actually not be able to predict risk. And that's why the approach now is to be individualized to every single patient, which means get to know our patients and have good conversations about them, how to decrease their risk.
So if I understand you correctly, then what your point is the difficulty in applying it to risk is you don't know if the person's at 10% without it, you don't know how this adjusts that 10 percentile risk.
Exactly. Well, also, like, I'll give you an example. I can have a 44-year-old woman who comes in with a very low cardiovascular risk, and you will say she doesn't need statin, she doesn't need any other interventions, but she could have lupus, she could have had preeclampsia in 3 pregnancies, and that increases her risk immensely, and that is not described by that risk. So we cannot rely on women entirely on the ASCVD, and we need to like have in mind when we are trying to predict the risk for that woman.
Thank you.
Yes.
Dr. Carbonell, that was excellent. Really excellent talk. And I was thinking, Gary, to your point of when I have middle-aged women or new patients to my clinic, I often will ask them about pregnancy complications. And with the admin of EMR, I'm just thinking, often the diagnoses have to be reconciled. And as soon as you see pre-E, like putting that as a pre-hypertensive diagnosis or pre-diabetes diagnosis, if they had gestational diabetes, like even putting that in their medical history would be important, because then it carries through. And it's just like, we have hypertension as a risk factor for ASCVD, but I wonder if like we actually say, we mark that as yes, not no, to see if their risk factors change. I mean, there's a lot more study that needs to happen, but sometimes that's how I frame it in my mind of like, you had gestational hypertension or pre-E, like your risk is already higher. I know that now. And let's make sure we add that, sort of fudge the calculator for what we need. As Dr. Carbonell was saying, like that's part of individualizing. I don't know, it's fascinating to me. I think pregnancy is fascinating disease process.
Absolutely.